Welcome back to the Wealth Eazy Show, where we talk all things wealth, health, and real estate. Today, folks, I've got a real special treat for you. We're going to be talking health and rejuvenating medicine, and my guest today is an expert in interventional, regenerative, and cellular medicine. He graduated from summa cum laude from the University of Pennsylvania with a combined degree in biology, psychology, physical anthropology. He has safely performed over 10,000 procedures and now uses delivery techniques learned over decades to precisely place regenerative cells for optimal growth and repair. He is board certified by the American Board of Anesthesiology and licensed to practice in Ontario, New York, Colorado, Florida, Texas, and Illinois. Please welcome to the show my sports doctor, Dr. David Smith. Welcome to the show.
Thank you. Thank you so much for having me, John.
Yeah, you've got quite a bio. Can you give my listeners just 2 minutes above and beyond what I've done? Because you've been around the industry a long time. You're not just like a family doctor or a practitioner. You specialize in chronic pain medicine. You're in the stem cell rejuvenation business. Can you give our listeners just a 2-minute bio before we go into the show?
Yeah, sure. So I started off as an anesthesiologist in the operating room, and when I was graduating from my residency, I did the job market was a little soft, and I was looking for additional training to distinguish myself from other candidates. And I did a fellowship in Seattle in regional anesthesia, which was training in how to give anesthesia to people without having to put them to sleep. So I got training in nerve blocks for just arm or leg or ankle or hand or whatever you were having done for surgery, and training in epidural and spinal anesthesia. And so when I came out and took my first job, I kind of was the anesthesiologist they sent the sickest patients to, because we wanted to avoid general anesthesia because it was more dangerous. And that training was also focused on helping patients with the pain that was going to happen after their surgeries as well. So we would, for example, if you were having a shoulder surgery, if you didn't have a nerve block for your shoulder, you would wake up in this, terrible, intense pain. And so the focus was not only on, the safety of not putting people to sleep, but also to give them a period of 8 or 12 or 24 hours when they woke up with no pain. So initially after my training, I already kind of had a focus on helping people with surgical pain. And so I got out of my training and worked mostly in the operating room. And then in 2010, a friend of mine started a pain clinic in Kingston, Ontario, and I was working just on the other side of the border in upstate New York. And he gave me a call and said, hey, practice is getting pretty busy and I need some help. And so I joined that chronic interventional pain clinic, which, that was, a new phase in my career. And I started undergoing new training and training myself and doing procedures for back pain and neck pain and injections in the spine. And then initially for, I think until around maybe 2013, 2014, I was practicing mostly with the traditional chronic pain paradigm, which is kind of like covering up the symptoms, with treatments that are sort of like just Band-Aids, and not really reversing anything, not really getting to the root cause of why patients are having this chronic back pain and chronic neck pain that is such a huge problem.
How many people do you think suffer from chronic pain? It could be back, hips, shoulders. Like, what would you say the the age group of the population, how many people would you say suffer with some sort
Oh,
of
it's just
chronic pain?
it's millions and millions of people. I think the number one reason a person goes to their family doctor is for chronic low back pain. Number one reason. It's billions of dollars of lost productivity, healthcare costs. It's just a huge problem. Low back pain, especially. So around 2013, 2014, we started to hear about platelet-rich plasma, and this was a new thing for us. And in our chronic interventional pain practice, we started to do a few cases with platelet-rich plasma, which is like a concentrate of platelets that's made from your blood, and the platelets are like the first thing that responds to any kind of injury.
Well, it's otherwise known as PRP.
Correct.
So yeah, because a lot of people know the term PRP. I mean, you've performed it on me and my shoulder. You've performed it once. Dr. Khan has performed it 3 times. I've had 4 rounds of PRP in my shoulder, which helped me to avoid surgery. I was recommended by some doctors to have surgery because I had tears.
Yep.
And the surgery was going to put me out of commission for several months, where with the PRP, my downtime was 2 weeks. I mean, I went home with the sling. You performed it just earlier this year.
Yeah.
I think it was February. You did the last round of PRP, and I had a arm sling for just a couple of days, but I was back to working out lightly in 2 weeks.
Yeah. Yeah. And then we have a lot of patients that are back in the gym in 6 weeks.
And how do you get that platelet? Because for a lot of people listening, they don't understand how you get those platelets out. Can you just explain the process of how you get the platelet and what you're actually injecting into the tear to avoid the surgery? Because I think this was incredible saving new technology for me that allowed me to be back in the gym and training within a matter of a couple of weeks. I wasn't in an arm sling for 4 months, and I didn't have to go through months and months of physio. So can you explain that? Because this is a really cool technology that for any of my listeners that are listening, that you have any type of a tear, this is, instead of avoiding surgery, you might want to consult Dr. Smith for another opinion on getting this PRP done.
Yeah. So the way that we make platelet-rich plasma is we take blood from the patient. And then we process it in what's called a 2-spin process. So we take the blood, we have it in canisters. It's placed into a centrifuge. The centrifuge is a machine that spins things in a circle and separates them according to weight. And so after the first spin, the blood is separated into a liquid portion and red blood cells. And the liquid portion above the red blood cells contains a variety of things, including platelets, which are the little fragments that float around in your body that respond to injury and initiate a healing response. And then there's also different types of white blood cells. And then there's proteins in the liquid plasma. Plasma is the name for liquid. And there's a variety of proteins. There's clotting proteins, and there are growth factors and anti-inflammatory proteins. And so we take the liquid off the top, and we throw the red blood cells away, and then we take that liquid and we spin it in the centrifuge a second time. And after the second spin, the platelets and the white blood cells sink to the bottom. If you look at the canister, it almost looks like a dust, like a red dust on the bottom. And then we remove most of the liquid. So that we can get the volume of the platelet-rich plasma small enough so that it can be injected into the place where we're treating. Sometimes we're treating very tiny little joints, and we want to get 5 billion platelets in a tiny, tiny little volume, so we can, for example, I've got arthritis in my thumb, and this joint doesn't have a lot of space in it. So we have to get the platelet-rich plasma concentrated way, way down into a small little volume so we can get it into that small joint. And then after we've taken most of the liquid off and we've resuspended the platelets and some of the white blood cells into that product, we often will take the remaining liquid and process it again and pass it through a dialysis filter to remove water, because there's still like really, really valuable anti-inflammatories inside that liquid. And so we concentrate that down, and often we'll be treating with both the protein concentrate and the platelet-rich plasma when we treat. Like, for example, for your shoulder, not only do you need platelets, but you need like protein scaffolding to kind of hold the platelets in place. Or sometimes we process the plasma and we make a clotting factor, and I combine the PRP and the clotting factor into a syringe, and I move it around a little bit until I can start seeing it just start to thicken up a little bit, and then I inject it into the tear. And once it goes into the tear, the clot forms, and the platelets are held in the clot, and then they'll release their growth factors over an extended period of like 2, 4, 6 weeks.
That's what you did for me.
Yeah. Rather than the platelets just washing away.
Right.
Exactly. But what I noticed in my pain practice was, at the beginning when I was doing traditional pain treatment, the patients always were coming back. Every 6 weeks they would have to have their injections again, because we weren't really getting at the root cause. And then when we started treating patients with PRP and later bone marrow stem cells from the bone marrow, we started noticing patients were disappearing. Like I would treat a patient and then I wouldn't hear anything. And a couple of months would pass and I'd be like, why didn't they call me? Where did they go? And then eventually we would track them down to do follow-up, and they were like, I'm better. I don't have to come back.
It's working.
We had never seen that in chronic pain.
Right.
In chronic interventional pain, we never had patients that came back and said, I'm doing better and I don't need to see you, Dr. Smith. Mm-hmm. When we saw that, our antenna went up, mm-hmm. and we were like, okay, we're on to something different now. And that was the beginning of this whole thing.
Hey everyone, it's John. I just wanted to thank you for being here, and I would ask that you please subscribe to the show by just clicking the subscribe button right here. I'd really appreciate it. It helps grow the show so we can get even more successful guests on the program to help you. If you're already subscribed, a huge thank you. When you subscribe, you're going to get access to the program before anybody else does. So if you would, just click subscribe right here. Thanks so much, and welcome back to the Wealth Eazy show. No, that's amazing. You also studied human behavior, and from a mind-body perspective throughout your career, what drove your interest into this connection? Because you did psychology too while you were in university. How did you get this perspective and actually discover getting into this connection of this chronic pain?
I think it went back to that initial fellowship where, I was getting, it was very rewarding to me to see my patients waking up comfortable, mm-hmm. And then the other patients in the recovery room that didn't get my nerve blocks, having more trouble and having to get injections of morphine and not doing well. And so I really got a lot of pleasure out of relieving suffering, and initially I was doing that in the setting of post-surgical pain. Mm-hmm. And then that ended up spreading, almost by accident. My friend started that pain clinic, and then I started, moved into chronic interventional pain and started expanding my interest in helping people with their suffering.
So I know that PRP is really good for tears. And I remember it was a couple of years ago that I actually had a tear in my rotator cuff. It was so large that PRP alone wouldn't feel, because at that time you weren't with Eterna Health. Dr. Khan was performing the procedure on me. Yeah. And what he had to do was he had to actually go in, make a cut in the side and extract some fat cells. Yeah. And he was getting all the fat cells that he was injecting into the tear, so that the plasma would hold.
Yep.
I found that I had more pain from the side of my,
Yeah.
and I said, don't worry, there's lots of fat to take from there. And the funny thing is he couldn't get very much from the left side. I'm like, there's lots there.
Yeah.
He had to go to the right side. He had to make 2 incisions to get enough fat cells. He was like poking me almost like you're doing a liposuction.
He was doing liposuction.
Yeah. And to inject, and now there's like a gel. After he did the graft,
Yeah.
now is there a gel that you could use if the tear is too large?
Yeah.
How does the PRP help with chronic pain? Because my sister has chronic lower back pain.
Right.
And you also treat a very dear friend of mine. I'm not going to mention any names, but he's been suffering with back pain for 12 years now, 10 to 12 years. And I say suffer like this. This is a man who we would play golf 5 days in a row. We go on golf trips and we would play every single day. It got to a point where he couldn't even get through 9 holes of golf without severe pain.
Yeah.
And I referred him to you, and you started treating him with PRP in his back. Now, he had no tears, but treating the PRP in his back. And I remember after a couple of visits to you, he said, I would pay $1 million to have this much pain as opposed to what I had before.
Right.
He said, before, on a scale of 10, 10 be the most extreme, it was a 10. He said, I'm like a 5 now. How does the PRP, the procedure that you did on him, because he didn't really have tears like I did. So how does that PRP work for the chronic pain that he's suffering with? And he says he feels better. Like he plays with me, my 2-day member guest. He can actually get through 2 rounds of golf, and by the second day, he's kind of hurting, but not like before.
Right. Yeah, I know. And we have a lot of stories like that where people say that, they may still have back pain, but they, but after successful treatment, they're recovering faster. They don't pay for it as much, and they're able to do those things that they couldn't do before. I think the poorly understood secret about chronic back pain in a lot of people is that it involves the soft tissues of the back. The ligaments and the muscles and the fascia, which is the connective tissue sheets that hold everything together and provide stability. Many patients are getting back pain from those soft tissues, whereas the big focus, the thing that most of the surgeons and doctors and the patients talk about are the discs. They focus on the lumbar discs. It's usually the patients will come in when they see me for their back consultation, and the first thing they do is say, "Hey, did you see my MRI report? Did you see I've got a bulging disc?" So they a lot of people have in their mind that if they have back pain, it's got to be their discs. But the ligaments are the forgotten thing in the back. And I think most people, they may not understand what the function of the ligaments are. Ligaments are, very durable, dense connective tissue that holds the bones together. And when I'm talking to my patients about about how the back works, I emphasize that it's sort of like an engineering structure, kind of like a suspension bridge. And if you have a suspension bridge, you have these towers and you've got these cables that, go across the towers, and the cables hold the bridge up. And the ligaments of the back function the same way. And over our lifetime, many of us are undergoing accidents. We have accidents in sport. We have accidents in our jobs. We have accidents in the gym. And when I talk to my back patients, I'm also, I'm usually gathering a history of what they've done to their back. And then I start finding out these surprising things. People tell me they fell from a ladder. They fell backwards onto a sidewalk. They had these different injuries where they probably damaged their ligaments. And So usually when I treat people's back pain, I start with ligament treatment, and I have an idea of how the suspension bridge is structured, and I know where the important cables are, and I start to treat those with PRP. So, in you, John, we treated your tendons with PRP, and the tendon is another example of a connective tissue thing that's connecting. It connects the muscle to the bone. Well, the ligaments are very similar, and they're made out of the same type of collagen structure, and they connect, your pelvis to your back. They connect different parts of your back to itself, and that's usually what I'm treating for 80% of the patients. I just did a big procedure yesterday on a young woman's neck, where I was treating the ligaments in the neck, and
you performed on my wife. Because I just want to make my listeners clear, it's not just for back pain. It's for any type of pain and tears. Correct me if I'm wrong.
Yeah, and I think that the ligaments of the back have little micro tears.
Yeah.
They're either stretched out too much and there's laxity. If the ligaments are stretched and they're not tight, then the engineering structure will be thrown off. And then when when the back has kind of some instability in it, that's been introduced because there's damage to the ligaments and they can't hold everything together, then the muscles of the back have to hold it. That's why your back gets tight. Your back gets tight because the muscles start firing, because the muscles have to do the work of the ligaments because the ligaments have been damaged. And most of the patients sort of don't understand how this works. After I explain it, they're sort of like, they have like an aha moment. They're like, oh, I think I understand how this problem is working. Yeah.
Well, with my wife, a couple of years ago, we were out golfing together, and she had a bad lie where the ball was sitting above her feet, and she was standing on the side of a hill, and she took a swing, and she hit the ground first. She didn't hit the ball. She hit the ground, and the moment she hit the ground, she dropped her club because she had a very sharp shooting pain go through her hand.
Yep.
She tried to complete the round. She couldn't complete the round.
Yep.
She waited a couple of days. She iced it.
Yep.
And then for weeks after that, she couldn't work out properly. She couldn't even hold a pot. Sometimes she dropped a pot. She's like, my hand just gave out. So we came to see you, and you did an ultrasound and found that she actually tore a ligament right around her thumb.
Yep.
And you did the PRP, and she's back to working out. She hasn't played golf yet because she's worried about hitting the ground. Also, she doesn't like my golf course where I play. It's very hilly, but she can't wait to get down south this winter and play in the Dominican where it's nice and flat, plays along the ocean. But the point being, we avoided surgery, and it was the PRP that was able to get her back into the gym and doing her regular daily routines without pain.
Yeah.
So that was really key. So that you did that just in her joint in her thumb area.
Yeah. And I mean, the patients are very, very keen on avoiding surgery because they have a good understanding that it comes with possible complications.
Yeah.
You may have a complication from anesthesia. You may develop a surgical infection. You may have the surgery doesn't go well. So as far as when we're talking about regenerative medicine procedure versus surgery, I usually say to the patient, well, surgery is like burning a bridge because once you have the surgery, you can't take it back. But if you have a regenerative medicine procedure, you're not really burning any bridges. Typically, it's either going to make you better or it's
you're strengthening a bridge.
Yep. Yeah.
Okay.
And that's the biggest advantage of what we do is to avoid surgery and possible complications.
I've always said health is wealth because your health is your most valuable asset a person can have. And in your practice, you've seen thousands of patients dealing with chronic pain. What would you say is the true cost of that chronic pain besides the medical bills?
It's like without a price. I mean, it's just like your friend said. where he said, "This is worth $1 million to me." Like you can't even put a dollar sign on it.
Mm-hmm.
That's what the patients say when they come back, and they say, like I took care of a young police officer, and she had been in a major car accident, and she was suffering for 8 years, and she had already had her discs treated. She went somewhere, she had her discs treated, she didn't get better. She came to me, and I said, I think if you're in a major accident, you may have damaged your ligaments. And we did PRP on all of her ligaments. And I think 6 or 8 weeks after we did the treatment, she was taking a trip to the Philippines, and she had to take a long flight. And when I saw her in follow-up, she after her trip, I saw her. I went into the reception area to say hello. She had a huge beaming smile on her face, and I said, "How are you doing?" She's like, "I'm doing really great." And she told the story. She said, "Well, when I took this trip to the Philippines, I took all, I was expecting that it was going to be bad, so I brought ice packs, I brought, warm packs, I brought pain medicine, I brought a back brace, and
Just
then
because she's sitting for so many hours on a plane.
yeah, and then she said, I'm on the airplane, and after a few hours, I'm noticing that I don't need any help, and I'm comfortable. And she had no trouble during the flight, and she had no trouble during her trip, and then she came back. That's priceless.
Yeah.
You just can't put a dollar sign on that.
Well, when you can go through life without pain, because I think when you're going through life and you have daily chronic pain, number one,
and she's a police officer back to work.
Yeah. Listen, right? I think this is one of the biggest causes, and you can correct me if I'm wrong here, of opioid addiction. And I personally know someone, a professional, who suffered with sciatica pain for many years. And he got addicted to Oxycontin to a point where you did, or if it wasn't you, it was Dr. Khan, did do the PRP on his back and his sciatica. It healed, but now he had to worry about coming off the addiction of the Oxycontin.
Right. Yeah.
That becomes a big problem.
That's tough.
That's tough because people have been ingrained as this mental thing. I need it because I have this pain, but now you perform this procedure, the pain is no longer there, but they've been departmentalized that I have to take this because of the pain. Are you seeing patients with this issue where now you've got to try and wean them off this medicine, this drug, because they no longer need it because now it's become an addiction?
Yeah, well, it becomes an issue of physical dependence. Their nervous system is used to it. Their cell receptors are used to seeing the opioids, and then weaning them off of it can take quite a bit of time because you can't do it cold turkey.
Yeah.
So it may take a period of months to very gradually, slowly decrease it, but it can be extremely difficult. So again, this is another reason why we're trying to develop this area of medicine so that we can avoid that for people. So that we don't have anybody being dependent. Like I saw a patient yesterday. She has low back pain and neck pain following a car accident, and she's got PTSD from the car accident, and she's got sleep problems, and the doctors have placed her on benzodiazepines, on tranquilizers. So she's on Ativan.
Wow. And
now she's been on Ativan for say 5 or 6 years. And that's an even more dangerous drug to get off than opioids. So we're trying to solve this problem, up front, so that if you have a car accident and you're having a lot of trouble in, 6 months after, you're getting aggressive treatment that hopefully can be effective in addressing the neck pain and the back pain, and never having people, have to go down that rabbit hole where, they end up being on a bunch of different medications, and then that becomes its own problem, So that's the impetus for all of the clinicians that are doing this clinical research to try to figure out how to help people more effectively and more rapidly.
Well, I think there's this trickle down effect. When I say your health is your wealth, it's very hard to operate at 100% if you are sleep deprived. You can't get a good night's sleep because of pain and lower back pain. I have never really experienced it, and I hope I never do. But from what I understand and what I hear from people that do suffer from it, it's the most excruciating pain. When you can't sit properly. Listen, I've had some back pain where I actually got adjusted. My neck was adjusted, and unfortunately, it was just this one time he cracked me. I don't know if it was the wrong way or whatever. I had slipped down some stairs and I jammed my neck. So my first opinion thing is, let me go get adjusted. I've been doing adjustments for years. Never a problem. Well, this caused a problem for almost 10 months where I had severe pain. It shot down my trapezius right into my lower part of my back, the middle part of my back, where just sitting for a while was very difficult. And I had to start doing adjusting spinal decompression. So I know what it's like to have pain and to not be able to sleep properly. And this now has this trickle down effect where you start taking these drugs and you become dependent on the drugs. So now you've cured one problem and now you've got to cure another problem. So I think what you're doing is incredible in helping people. We just have to figure out how to get people now off of this pain medication. Thankfully, my friend who you helped with his sciatica, he's off the opioids. He no longer is dependent on them, and he plays golf 5 times a week. Mm-hmm. He has no pain.
Now, this was another thing that we saw, in the chronic interventional clinic where I was working. When we started doing regenerative medicine, we would occasionally see the patients. They would come back and they would say, I stopped my own pain medicine.
That's great.
That never happened for any of the traditional treatments we did. Nobody ever came back and said, I weaned myself off of my medication. Mm-hmm. Never. And now we were sporadically seeing people coming in, I don't need my naproxen. I stopped my Percocets. I don't need my Lyrica. I just stopped them all.
It's amazing.
I know. We were sort of like stunned by that.
It's like a whole new life for these people.
Whole new life, and a complete paradigm shift in medicine. I tell people that this is, the future. The future of medicine is this, cellular, biologic, genetic, type treatments are the future. Surgery is going to, there's still going to be a place for surgery, but there's going to be large segments that are going to be, start kind of fading away. Because they're going to become unnecessary for many people.
Well, I think if you can avoid surgery, avoid it at all costs. So I want to go past the PRP because now there's even newer technology that you are involved in, which is stem cell therapy. Yeah. And I think the last couple of years, this buzzword has been gaining momentum because of the incredible health factors stem cell has. And now I know that you and Dr. Khan are now like developing exosomes, which is like
exosomes.
Exosomes, which is what you recommended because I now, after tearing my shoulder for 4 times and the amount of pressure I've put my shoulder through in the gym over 35 years of training, I now have advanced osteoarthritis. Yes. And you're saying that this can be treated with exosomes. So let's get into, because this is now, I think, like the future of, and you're really getting involved in this, in the future of stem cell treatment and exomes. So let's talk about stem cells because there are different types of stem cells.
Yep.
I understand. Can you explain the different types, the uses, and let's talk about some exomes because a lot of people, because they're saying, listen, there's no treatment for arthritis, but kind of there is now.
Yeah. So I'll give you a little background on, on how we discovered the connection between stem cells and osteoarthritis. One of the major researchers behind the relationship between stem cells and osteoarthritis is a orthopedic surgeon in France named Philippe Hernigou, and he's a doctor who, in my opinion, should get the Nobel Peace Prize for medicine. Mm-hmm. But he's still a little not well known. He's very humble, and not the kind of person that talks himself up. And he's about 30 years ago, he was, wondering about osteoarthritis and how it worked, and whether it might have some sort of relationship to the stem cells inside the bone marrow space. So let me explain a little bit. Most people think that that their bones are solid all the way through, but they don't understand that your bone kind of has an outside shell that's made of a very dense, compact form of bone called compact bone, and inside the shell is a delicate web work of a different kind of bone called trabecular bone. You can kind of think of it almost like as a web, like a spider web of very delicate bone filaments with space in between, and the spaces are filled up with the bone marrow, and the bone marrow includes all of the blood cells inside the bone, the red blood cells, white blood cells, the stem cells are there, precursors for all the different kinds of blood cells that your body needs, and on the surface of the bone is the layer of cartilage, which is that kind of cushion that, again, most of the patients are familiar with the idea of cartilage because the surgeons talk a lot about the cartilage and how the cartilage gets worn away. But the forgotten part is the bone marrow area underneath the cartilage, which nourishes the cartilage. Mm-hmm. Sort of like the cartilage is like grass, the grass of the garden, and the marrow is like the soil. And Dr. Hernigou wondered whether there might be some kind of problem in the bone marrow space underneath the cartilage. So he took a needle and he put it into the bone marrow space of patients that had very bad osteoarthritis, and he sent it for culture to see how many stem cells there were. And he would sample the healthy knee. He would take patients that had one very arthritic knee and one healthy knee, and he would culture both of them to see how many stem cells there were. And he found that the knees that had arthritis had stem cell depletion. There weren't enough stem cells in the bone marrow. There was something, some sort of problem there that was resulting in not enough stem cells, and if there was stem cell depletion in the bone marrow space, then it couldn't nourish and support the cartilage. And now the cartilage is breaking down because of a lack of stem cells, not because of wear and tear. There is an effect with wear and tear, but we discovered that there was a big problem in the bone marrow space too, and that there weren't enough stem cells there to nourish and support the cartilage. So after he made that discovery, he made the next conclusion, which was, well, if I harvest bone marrow stem cells from a different part of the body where the stem cells are healthy and plentiful, and then I put it into the bone marrow space, maybe the patients will get better. Maybe I can reverse some of this osteoarthritis. And so that was his next study. He harvested bone marrow from the back of the pelvis, put it into the bone marrow space underneath the cartilage, and lo and behold, he showed studies where the MRI scans would change.
Wow.
The cartilage would recover, and the bone marrow space would would show recovery on the MRI scan. So he was the first person who made a connection between stem cells and osteoarthritis, and then that set off the rest of the research. So so now, and again, just to explain what exosomes are, exosomes are like the little signals that the stem cells make to tell other cells what to do. So if the stem cell sends an exosome to a macrophage, which is another kind of white blood cell, and instructs it to change what it's doing, another thing that we've discovered is cells can act differently in different situations. So, for example, you can think of a cell as like a construction worker, and you might say to the construction worker, go into the house and demolish the walls, tear things down. And in a different situation, you would say to the construction worker, okay, today I don't want you to do that. I don't want you tearing things down because we're done with demolition. I want you to start putting the 2x4s up and putting on the drywall. So the construction worker can do different things. They can, and the cells in your body can do different things too. Your cell can be programmed to be inflammatory, or your cell can be programmed to be anti-inflammatory. And so if the stem cells, give instructions to all of the cells in the area, and they may make a little exosome that sends an instruction to a white blood cell and tells it, I don't want you to be inflammatory right now. I want you to stop that. I want you to be anti-inflammatory right now. And that's what exosomes do. The stem cells use exosomes to send signals out to the cells to give them instructions on what to do.
Incredible. So in my case, with my arthritis, because, I have very minimal movement and I do have a lot of inflammation in my shoulder. I can't, there are times just lifting my shoulder above just to put deodorant on is sore. I mean, I don't have any more tears. You took care of the tears.
Right.
But now this arthritis is preventing me from movement.
Yep. And often that movement is inhibited by pain.
Correct.
Yep.
Correct. So would you inject the exosome or a stem cell with exosome into the joint of my shoulder to reduce that pain? Like, what would it do?
We'll usually use a combination. So we'll, typically we'll use exosomes inside the bone marrow space, and then often we'll put the stem cells into the joint liquid space. So we're treating on both sides of the cartilage. We're treating on we're treating the soil, and then we're irrigating the grass. Okay. So we put the stem cells into the joint liquid, which bathes everywhere inside the joint, and then we use special needles with ultrasound or X-ray guidance to put them into that bone marrow space just underneath the cartilage, and then we treat those with exosomes that are designed to reverse that inflammatory reaction that's inhibiting nutrition and support for the cartilage.
What is arthritis? Is it an inflammation? Is it a disease of the bone? Like, what really? Because people hear arthritis all the time, but really, what is arthritis? People get in their joints, like you said, you got it in your thumb and it restricts movement. Like, what is it, and how does that cure it?
The old paradigm of arthritis, when 30 years ago, when you went into the doctor's office, and they said, you have an arthritic knee, they would say, it's caused by wear and tear. You've used your knee a lot and you've worn the cartilage down, and now there's areas where the bone is, they'd use this phrase, bone on bone.
Mm-hmm.
The bones are touching, and that's causing the pain. And it was a very, kind of mechanical explanation. And the other type of arthritis, rheumatoid arthritis, which was known to be more of an autoimmune disease where your body was attacking itself and destroying the bone and destroying the soft tissues around the joint. And we thought that those two things were completely different. One of them was just wear and tear, and one of them was an autoimmune disease. What we now know is that rheumatoid arthritis and osteoarthritis are closer relatives than we thought, and they both involve the immune system. So you can think of osteoarthritis it's really a cellular disease. The way that I explain it to the patients is it's sort of like in a healthy joint, all of your cells and your tissues are doing what they're supposed to do. And when the bone cells die and they get replaced properly. And the cells of the joint capsule and the ligaments, and they're all doing their job. They're all acting properly. When the joint starts to become osteoarthritic, it's almost like all the cells in the joint start not following their proper instructions.
They've got no job description.
I sort of describe it to my patient as kind of like, you left your 4 kids at home and you went on a vacation and you didn't leave a babysitter. Mm-hmm. And they all just started doing whatever they wanted. They started breaking things in the kitchen and leaving trash around the house and, not doing their chores. It's sort of the same thing happens in the joint.
It's chaos.
Yeah. The bone cells start not being replaced properly. You start developing bone spurs because, they're not rebuilding the bone properly, and then there's an inflammation and immune response happening in the bone marrow space, and the stem cell population is being depleted, and the inflammatory cells are acting overly inflammatory, and the capsule that surrounds the joint starts to get thick, and too much tissue, and the synovial cells that normally make the joint fluid start putting out too much joint fluid because they're inflamed, and that's why your knee starts swelling, and because of abnormal signaling, abnormal nerve fibers start growing into the cartilage, and tiny little abnormal blood vessels start growing into the cartilage, and the barrier between the cartilage and the bone marrow space starts breaking down, and so it's like a form of chaos. And somehow we need to bring the parents back, and we have to get the children under control. We have to make sure that all the cells are reset and start acting properly again. And that's the role for bringing in the stem cells and the exosomes, is to try to give them proper instructions and to bring in a healthy population of stem cells to start giving instructions to the cells and to shut the inflammation off and switch this environment from toxic to healthy.
Got it.
It's a correcting of the environment.
That's a really good explanation on how you use kids at home being chaotic, and because for a lot of people who don't understand medicine, like I don't understand medicine, but what you just said I completely understand and how it works. So I know there's different types of stem cells. There's a placenta, stem cells.
Umbilical.
Is there a real difference in the treatments that you use? Because you just use stem cells for arthritis. Stem cells are now being used for anti-aging, tissue, like repairs of tissue. Our friend that we spoke about with the back pain, who said he'd pay $1 million to feel this good, he has now done, I believe, 2 rounds of stem cells in his back with you, and he's saying, I'd pay $2 million to feel this great.
Yeah.
Because now he's even feeling better than the PRP. So the 2 different types, you got umbilical and you got placenta. Are there different uses or different cells that are coming out of that? And what other uses are you finding treatment for today?
The first division is where are we getting the stem cells? Are we getting the stem cells from the patient themselves, or are we getting the stem cells from donated tissue? So sometimes, they'll harvest bone marrow from the patient, and then they send that bone marrow to the laboratory to make more stem cells. That's called culture expansion. So you can have culture expanded bone marrow stem cells from the patient themselves that later on is given back to them, okay? Or you can do culture expansion of stem cells from donated tissue. So for example, if you have healthy women that are giving birth, and instead of throwing the placenta away or throwing the umbilical cord away, they go into the placenta or the umbilical cord and they harvest the tissue where the stem cells are in the placenta or umbilical cord, and then they send those cells out to the laboratory to be expanded. So that's donor culture expanded umbilical stem cells. So those are two groupings. You can harvest, you can get bone marrow stem cells from the bone marrow, or you can get stem cells from the umbilical tissue. The advantage of getting culture expanded stem cells from the umbilical tissue is that those stem cells can be harvested from young, healthy donors, whereas, let's say you're 65 years old and you've got an osteoarthritic knee. If they culture expand your bone marrow stem cells, then potentially the stem cells are aged and aren't going to be as healthy and functional as a 20-year-old woman who's giving birth. So the advantage of the umbilical stem cells is that they're from healthy young patients. The stem cells that we're using don't have the markers on the surface of the cell that would cause them to be rejected. So you can get stem cells at an early enough stage in their development that they can be given to someone without tissue matching. Like you don't have to match it like you have to match a blood transfusion.
Right.
Then now if you separate the source, you can have bone marrow as the source, you can have the umbilical tissue as the source. Then the stem cells can actually be divided into even more subpopulations. Okay, so in our clinics overseas, we're using a particular subpopulation of stem cells called Muse cells. That stands for multi-lineage stress enduring. Okay, so multi-lineage means they have the ability to form different tissues. They can turn into ligament or cartilage or muscle or bone. That's what the phrase multi-lineage means. Stress enduring means that they can survive in harsh environments. And the Mari Dewaza is the Japanese scientist that discovered the Muse stem cells. And when I met with her recently in Dubai, and my first question to her was, how did you discover these Muse cells? Mm-hmm. And I said, before you tell me, I'm guessing it was an accident. Mm-hmm. Because most scientific discoveries are
accidents.
Are by accident.
Yeah.
And she smiled and she said, yeah. She said, I was in my laboratory and I was, laying out cells for culture, and my friends were having a cocktail party, and I was late for the party, and they were repeatedly calling me and saying, "Are you done? Are you done with your work?" And she said, and I kind of was rushing, and I finished my work, and I went to the party, and I came in the next morning, and I discovered that I had cultured the cells improperly, and I had added something to the culture that typically would kill them all. And then when she looked into her culture plates, she saw that there were some cells that survived. And that's how she discovered the Muse cells, because she had done something that should have killed them all, and then saw that there were this subpopulation of stem cells that survived, and that was the beginning of her trying to figure out, okay, what are these cells and why did they survive? So we're using those stem cells because we're treating places in the body that have harsh environments. The lumbar disc, it doesn't heal well, and it doesn't maintain well because it doesn't have a lot of blood flow. It doesn't get a lot of oxygen. It has sort of an acidic environment that makes it kind of hard for things to survive. So that's that's why we were so interested in using the Muse cells. The other thing that's special about the Muse cells is they have a homing mechanism. So she did clinical studies in patients that were having strokes or heart attacks, and the Muse cells were given in the IV. And you might say to yourself, well, how do they know where to go? You put them into the blood and they start circulating everywhere, but how do they know where to stop? So it turns out that when your cells are damaged, they express a little marker on their surface, and the Muse stem cells have a way of recognizing that marker. And so as they're going through the circulation, when they come by, when they pass by heart muscle cells that are damaged, they stop, and they use that homing mechanism to stay there and encourage the repair. So in these two clinical studies that she did, where they treated stroke and heart attack, the stem cells that were given in the IV, the group that got the IV Muse cells had better recovery of the heart cells and the brain cells. So this is another example of the future. In the future, when you're having a stroke, you'll go to the emergency room and they'll give you an infusion of stem cells to halt the inflammation, to stop the tissue destruction, and to give your cells help in repair.
Amazing.
It's just amazing.
Yeah, to say the least. Now, there are several ways to administer the stem cells. You can do it by injection directly into the area, or just by IV.
That's correct. Usually when we're treating musculoskeletal problems.
Like for my case?
Yeah, like for your case, we inject them directly into the area.
Okay.
So we may put some stem cells or some exosomes in the area of the tear, and then it's my belief that that there's sort of like a surrounding area around the tear where the tendon tissue looks healthy, but it's probably not. It's there's probably like a border area that's also a little suffering as well. So I often will treat in the area of the tear, but then I also treat in this area of the tendon around the tear, both to treat areas of that quote healthy appearing tissue that might not be completely healthy, and also encouraging that area of the healthy tissue to support the tear, because it's gonna heal from outside in.
Right.
When we're doing the musculoskeletal stuff, we're doing targeted treatment because we know where the area is that needs to be treated. But if we're taking care of people that have autoimmune disorders, they have lupus, or they have rheumatoid arthritis that's involving so many areas of their body, or areas that you can't get at. Like right now, we don't have the ability to put a needle into somebody's brain and get right near the stroke area and inject, cells around that brain tissue. In those kinds of situations, we put them in the intravenous line, and then we let the Muse stem cells use their homing mechanism to do that.
Got it.
Okay, to circulate around and then stop where they're needed. The thing that we're discovering is there's so many diseases that seem to have an inflammatory cause. It's becoming apparent that dementia is inflammatory. There's an inflammatory mechanism to dementia. There's probably an inflammatory mechanism to chronic depression. And so, again, this is the future of treating these diseases, is to address the systemic inflammation that's causing them.
So are you saying that in the future you're seeing, with, I guess, more research, that these type of stem cells can treat, say, dementia or maybe Alzheimer's, stroke? What about
that's
things
going to be the future? We're still working that clinical
Right.
research out, but I think that's where medicine's moving.
That would be amazing.
Yeah.
Now,
Same thing. Get to the root causes, right?
Yeah. Can people also do stem cell treatments just as preventative if they don't have any root causes? They just want to, say, prolong life. I mean, I've seen stuff by Gary Brecka.
Yeah.
Do you know who Gary Brecka is?
Yeah. Yeah.
And he's saying that with proper nutrition, eating properly, if you understand your body's DNA and the foods and things that you should eat for your body's DNA, that he's seeing people living to like 120 years.
Yep.
Would you agree with that? With the future of stem cells, can people use this as a preventative for extending their life?
Yeah. I mean, I think that that question is still being answered. I mean, we know that aging is related to an increasing inability to maintain your tissues. The belief is that the stem cells begin aging, the stem cell population starts dropping. Like if you look at stem cell numbers over the course of your life, they decrease. They get fewer and fewer and fewer as you age, and we know that the stem cells are responsible for managing all of the cell populations. We know that they're key to tissue maintenance. The assumption is that if we can give ourselves infusions of healthy stem cells and keep those numbers up, that we may be able to increase longevity. But we're going to get that answer over time.
So really, if you have the means to do so, meaning you've got the wealth,
Yeah.
you can literally go and sit and get an IV drip. And how many cells would be in like a drip? Like 50 billion cells or something like that?
Well, we're giving right now our longevity treatments. We give 20 million used stem cells, somewhere between 20 to 100 million, depending on the situation.
Okay.
And 1 trillion exosomes.
Wow. And that's just in an IV drip, and that's just life extension.
Yeah. And we know from the clinical research that there are a lot of different kinds of clinical studies where intravenous stem cells were used without any reports of any major complications.
Now, when you're talking about treatments for like my arthritis,
Yep.
Are you doing those treatments in Canada, or are you doing them outside of Canada?
Outside of Canada.
And why are you doing them outside?
We have clinic right now. Our clinic locations are in Cabo and Dubai.
Okay. I know.
And Lithuania, we're doing some treatments there.
Yeah, and I know my friend, he went to Cabo's and he stayed on a very nice resort and right near the clinic. Is it because Canada has a restriction on the amount of cells that you could use, or the type of cells?
There's restrictions. In Canada, in order to do this kind of work, we would be required to be running a clinical research study, and the stem cells would be classified as a drug, and so we would have to have a new investigational drug application, and a clinical study with an investigational review board, and all of these things. To do this, might cost $1 million to just run a clinical study. So in Canada, the cost is prohibitive. We'd be unable to treat patients. So it's just a regulatory issue.
So
they haven't really put together a new regulatory framework,
right?
That would lower the cost of being able to put together clinical studies in particular settings where people have no viable options. Like in the United States, I believe they're starting to develop right to treat legislation, it's called, where if you have a particular problem and your options are limited, make it easier and less costly for doctors to do clinical treatments that are more advanced and a little bit more on the edge. Instead of having the same regulatory requirements anytime that you want to treat someone.
So by treating,
so we just need a new framework. This is it's a new area of medicine, and the regulatory framework, just hasn't really kind of caught up yet, and we haven't been able to discuss with the government to explain to them the chronic pain problem, and how most of the patients are not really doing well, and we need a little bit of regulatory help to be able to offer treatments that we do think have a good safety profile for those patients that don't really have a lot of options, who are the way that you had described are the different patients that you talked about, where before getting these types of treatments they were disabled, they couldn't work, their productivity was gone, we need a new regulatory framework to allow us to try to help those patients.
Mm-hmm. Mm-hmm. So,
I mean, the patients I saw yesterday, they're disabled.
Yeah.
Their lives are being destroyed.
Yeah, I think Health Canada needs to come up with some better options, and maybe some more consultation from the practitioners like yourself to offer Canadians more options to treat this chronic pain and these problems. Because I think if we can treat the problems for the people that do have the means to do so, it's certainly, I think, going to take some relief and burden off of the system with the medications and the constant trips to the hospital or the doctors with all the visits. I think it's just going to help those people much more than the treatment and the medications that are occurring. Because I think most of the stuff right now is more of a Band-Aid.
Yeah, we've always been willing to sit down at the table and work together to try to come up with a better framework.
So for treatment,
but right now we've had to go offshore.
Yeah, what investments in health in investing in your health today you think might be the biggest payoff in the next 10 to 20 years that people can do?
Explain a little bit more what you mean.
Well, what can people invest in right now and today in their health that you think that will have the biggest payoffs for them 10 to 20 years from now?
In their own life?
Yeah.
I think probably the low-lying fruit for health. The first things that come to my mind are stay out of the center of the grocery store.
Right.
Okay.
The foods we eat.
Don't go in the middle of the grocery store. Don't go into any of the aisles.
Yeah.
Stay on the outside. So you want to eat only whole foods. So you go to the vegetable aisle, you can go to the cheese, you can go to the milk, you can go, to the meat, you can get, grass-fed organic beef, make things simple at home, but don't eat anything that didn't exist 50 years ago.
That is such great advice. Yeah.
Right?
Yeah.
So don't eat anything that's ultra-processed. A lot of people don't know what ultra-processed food means. What it means is if it didn't exist in 1920, don't eat it.
Yeah.
Right. And then that goes for cooking oils.
Mm-hmm.
I tell people, don't use natural oils. Nothing, again, if it didn't exist before 1900, don't eat it. So you can have butter, you can have ghee, you can use olive oil,
coconut oil,
avocado oil, coconut oil.
Yeah,
those are all real oils.
Yeah.
Right. So
I think canola is the worst, right? Peanut oil, canola oil, the worst.
Next thing you can do is 10 to 20,000 steps a day.
Mm-hmm.
Walking. All you have to do is walk.
Yeah.
You don't even really have to be in the gym. There's a
And that's free.
huge longevity and all-cause mortality decrease just from, I believe the threshold is 10,000 steps a day. So that's one thing.
And that doesn't cost anything.
Doesn't cost anything. Sleep.
Yeah.
Sleeping 7 hours. go to bed at the same time every night. We struggle with that.
Yeah.
Stop using your screens, for an hour or two before you get ready to go to sleep. So, because most people think, that once they go to sleep, all sleep is equal. They don't realize that if you go to sleep after being stimulated, by looking at screens and looking at Twitter and Instagram and everything, and then, that you don't get the same quality sleep.
Yeah.
But you really want to go to sleep at the same time. You want to get, 7 hours. You want to wake up at the same time every day. That's going to set your circadian rhythms. Seeing sunlight in the morning, just simple things like that. So I usually focus on eating, sleep, diet, activity. If you have trouble initiating sleep, consider doing guided meditation. That's very easy. It's free. All you have to do is find a guided meditation online.
I started meditating probably about 2 weeks ago.
Yep.
I get up at, I was getting up at 4:30. Now I'm getting up at 4.
Yep.
I go down to my office. I sit straight up. It's got a dark room. I put my earplugs in, and I've got a couple. And you go on YouTube, you can find meditation music. You can find people that are actually going to talk with you and how to get into meditation, into your alpha. I recommend a book by Jose Silva. He teaches you actually how to get into that state and how to do the meditation. Honestly, I've discovered that my wife says I'm more calm, and it's harnessing in on your third eye, which is, they say it's right around just between your eyebrows there. It's your real mental awareness.
Yep.
And when you can tap into that, you can pretty much get anything that you want and that you desire. I've been doing 20 minutes of meditation each morning. Then I go through the rest of my routine. When you say sunlight, yes. And we're entering into the winter time, I would highly recommend getting yourself some red light therapy. You can get red light panels.
Yeah.
My wife's now looking in this weekend. We're going to be picking up some red light panels, and I'm going to do my meditation in front of the red light panels and get that UV, because it's really important that we get that UV. You mentioned food. Oh my God. That is one of the best pieces of advice that you could ever give anybody, in staying away from the center of aisles. I've never heard that before.
Yeah.
But yet, if you think about it, that's where all the crap is.
Yeah, I know.
Right?
Yeah.
And the biggest thing that parents, if you're listening, stop feeding your kids cereal. Look into the ingredients. It's full of sugar. Sugar equates to inflammation.
You know how many children are pre-diabetic right now?
It's the sugars. It's the sugars.
30% of children are pre-diabetic
Stop
right now.
feeding them cereals.
Yeah.
Get them on a healthy breakfast. Get them on oats. Get them on eggs, bacon, turkey bacon, healthy fats.
Yep.
I stopped giving my son cereal years ago. I was watching him put on some weight. And
and my oldest son is looking that way too.
Yeah.
Which is another thing. They don't teach cooking in high school.
Yeah. And
right?
it's
so kids don't know what to, when they get out of high school and they're in early adulthood, they don't know what to eat.
Yeah. It's incredible what sugar does to the body. My son, who's now 13, back in around August, it's so funny because he said to me, Dad, I want to start going to the gym with you. So in the summertime, I would bring him to the gym. And I've noticed he's really taken a liking. I've never forced him, but he's now starting taking a liking to working out. I guess he's getting that age. He's kind of looking at girls. Maybe girls are looking at him. And he said, Dad, do you have any photos of when you used to compete in bodybuilding? So I started showing some photos when I used to compete and when I modeled. And he's like, Dad, you're jacked. How do you get a body like that? And I said, well, first of all, son, abs are made in the kitchen, not in the gym. He's like, well, what do you mean? I said, you want a body like that? You got to start in the kitchen. You could work out all you want, but if you're leaving the gym and you're going to McDonald's and you're eating shit and you're eating Subways, so like not even Subway, you're just eating subs and you're eating all this, like you say, this food that is not even, it's processed food. It's not coming from the ground. and you got to cut your sugars. My son would, every night after dinner, he'd eat a plate of pasta. And then he'd say, Dad, can I get a Nutella bar? Can I get a Nutella cookie? Can I have this? He wants the sugars. And I said, you got to cut that stuff. I didn't force him. He did this on his own. You know, we just got back from Nashville, and I spent some time with him for the last, 4 or 5 days, and he's lost so much weight. And I said, you're looking really lean. He says, yeah, Dad. In August, I was 197 pounds. I'm 170 pounds now. And all because he cut sugars. And the other thing that I noticed is his grades. I just got his report card. He's in grade 8. His grades last year, he was a great student. He's an above average, like he's in the 80s. But you know what? He had a couple of B's, a couple of B pluses, a few A's. This year, this first term, he had nothing less than an A. And I strongly believe that by him cutting these sugars, and he doesn't crave it, he has no brain fog.
Oh, yeah.
He has no inflammation.
Yep.
He's looking healthier. He's a swimmer. He's on the swim team. Mm-hmm. He says, Dad, my time is so much faster than last year. I'm like, yeah, you're not pulling 27 pounds behind you. Mm-hmm. And he's motivated, but I think it's one of the biggest causes of kids in school is the brain fog caused by the sugars and the inflammation, weight gain, sugars. Mm-hmm. After eating, after dinner, they want a little snack. He doesn't even want that anymore, So
good for him.
Yeah, he's incredible, and his mother is very proud of him. And the other bit of advice that was given to me by someone else who's on the show, Dr. Janine Bowering, she's a nutritionist and she's a naturopath. Mm-hmm. And the one thing that she had said is, don't have a meal 3 hours before bed.
Yep.
And stop drinking 2 hours before bed. I would sit with my wife, and we would, 1 hour a night, we watch a show together, and I would sit with my bottle of water next to me, and I would drink that right up until we go to bed at 9:30. I can't get a full night's sleep because I'm up 3 times in the night to go to the bathroom, and then sometimes, with me, I don't know what's like you, but I get back into bed, and my brain starts going.
Yeah.
And I can't get back to sleep. When I started cutting my water at 7:30, and my last meal is at 3:00, my insulin is not elevated when I go to sleep. Mm-hmm. I get such an incredible sleep. I might get up once now during the night to go to the bathroom.
Yeah.
And there's sometimes where I wake up, it's like, holy shit, I just slept 7 hours and I never woke up once. Like, I feel incredible. You're not tired or anything. So really great advice.
Another great one is after you have a meal, if you have a treadmill in your house, walk for 30 minutes.
Yeah, and
just get some exercise after you eat.
Think about that. Look at the people in the U.S. and look at the people in Europe.
Yeah.
What are they doing? What are they doing after dinner in Europe? They're going for walks.
I know.
My wife lived in Italy. My wife was in Tuscany.
Yeah, my dad lived in Scotland. They were always going for walks.
After dinner, they go for a walk. They're lean. And you go, how do they get to eat all this pasta and this pizza? Well, number one, they don't have all the chemicals in the breads, right?
Yeah, different wheat.
Different wheat, right? I noticed that when I go to Italy, you've been to Italy, I can eat pizza and pasta and I don't walk away feeling so bloated. I feel fine.
Yeah.
And you're walking everywhere.
Yeah, everybody says that.
Great advice.
Yeah.
Get on a treadmill, walk for 30 minutes, or just go outside, get some fresh air.
Yeah.
Go for a 30-minute walk in your neighborhood.
Yeah.
Really great advice.
This morning it was sunny.
Yes.
I notice immediately a change in my mood when it's sunny.
Yeah.
It's crazy.
Totally. Last week, my wife and I, we were in Orlando. I had a conference and she came down. And I noticed my wife gets off the plane. The moment we step outside, it's blue skies.
Yeah.
And my wife goes, I don't know what it is. My mood has changed. Like I feel happy.
Yeah, I know.
Like everything's changed. And I notice my mood has changed when you're out in the sun.
I know.
So get out, get some fresh air, go for walks after dinner, go for a walk in the morning, take your dog, go for a walk with your spouse. It's fantastic.
Yep.
If you can't do that, red light therapy, like you said, the UV is amazing.
Yep.
This has all been really great.
Yeah.
Now, the next question is, how can people find you that want to get treated with this plasma rich, this platelet therapy, the PRP, or they want to discuss with you, maybe getting some stem cell treatment?
The best way to get in touch with us is to send us an email at careteam@eterna.health. So
Okay.
that's careteam@eterna.health.
Okay.
And then we'll get back to them. And our clinic here in Toronto is in Mississauga on 3095 Glen Erin Drive. And it's easy to find on Google Maps.
Yeah,
got the phone number there. So just give us a phone call or send us an email.
Yeah,
We'll be
amazing.
happy to help.
This has been amazing. Guys, while wealth can buy many things, it cannot replace good health. And by prioritizing your health, you invest in a full life of opportunities, productivity, and happiness. And having said that, that's all for today. Take care of your wealth and your health.
Thanks, John.
Thank you, Doctor.